Patients who are found to have stage 1 colon cancer, by and large, don't require any other therapy besides surgery, and the reason for that is that most patients with that stage of colon cancer are cured by the surgery. Some patients with stage 2 disease may be offered chemotherapy. Why is this done? Well, after surgery, certainly your surgeon may have told you, I got everything I could see, and that is true. However, we know that some patients will go on to develop recurrences of colon cancer in other parts of their body in spite of having successful surgery. One way we can prevent this is via the administration of chemotherapy to, for example, kill any microscopic deposits of cancer that might have existed at the time of surgery. Stage 3 colon cancer means that the cancer has spread from the site it began in the colon to lymph nodes nearby. Lymph nodes are like little filters the body uses to drain fluid out of organs. There are lymph nodes in many parts of your body, and your intestines are no exception. We find these lymph nodes by looking at the surgical specimen. When your surgeon removes your cancer, he or she also removes part of the normal colon and what's called the connective tissue around the colon, and that connective tissue is where the lymph nodes are found. When your surgeon has taken the tumor and part of the colon out, it is given to a pathologist who then looks for lymph nodes in the connective tissue and examines those lymph nodes under the microscope to see if there's any evidence of cancer in the lymph nodes. If that is the case, if there are tumor deposits or small tumors in the lymph nodes, then your tumor would be characterized as stage 3. The implication of this is that the cancer is more likely to have spread to other parts of your body than if the lymph nodes are not involved by the cancer. For example, if you take a patient with 1 or 2 or 3 positive lymph nodes in their colon cancer sample who is only treated with surgery, there's about a 30% chance that the cancer will recur at some point in the next few years, usually somewhere else in the body like the liver, other lymph nodes, or perhaps even the lungs. We try to prevent this from happening with the use of chemotherapy. Chemotherapy simply means drugs that are given to you to try to attack any small or microscopic deposits of cancer wherever they might be in your body. For most patients with stage 3 disease, we use what is called combination chemotherapy, meaning 2 or more drugs to treat the small deposits of cancer. One thing that's important to understand is that it's possible that your cancer has been cured by surgery alone, and we don't know who does and does not have these small deposits. So there is a lot of uncertainty surrounding treatment and who needs to be treated with stage 3 cancer, but the frequency of recurrence is enough that we believe that essentially all patients who can tolerate chemotherapy should receive chemotherapy if they've been given this diagnosis. The 2 main chemotherapy types we use to treat stage 3 colon cancer are fluoropyrimidines, and the fluoropyrimidines include an oral drug called capecitabine and an intravenous drug called 5-fluorouracil. Those can be used interchangeably. And the second drug that is most commonly used for stage 3 colon cancer is called oxaliplatin. The fluoropyrimidines have few, if any, known long-term side effects, meaning that any side effects you'd experience during chemotherapy are likely to go away for good when chemotherapy is finished. Oxaliplatin does have one potential long-term side effect, which is called neuropathy. And generally, neuropathy is something that a patient would experience as numbness or tingling in the fingers, toes, hands, and feet. And this is a side effect we try to prevent by stopping oxaliplatin if this symptom begins to occur while a patient is receiving their chemotherapy. Once you've completed therapy for your colon cancer, and this applies to stages 1, 2, and 3 colon cancer, we do something called surveillance. Surveillance is a term for watching for signs of recurrence. And there are a few tests we do that are useful in finding recurrences at a point where they can still be treated. The main tests that are done during surveillance are physical examination, a blood test called a carcinoembryonic antigen or CEA test, colonoscopies, and in some patients, imaging studies such as CAT scans, MRIs, or PET scans. These tests are initially done with relative frequency, and then as you get farther and farther out from the time of your treatment, if there's no evidence of disease recurrence, the surveillance tests may be spaced out farther and farther until we feel that it is safe to release you to your primary care physician for long-term surveillance. With colon cancers, it appears that the majority of recurrences that are going to happen within the first 3 years, and almost all of the recurrences happen within 5 years. That means that if you've been followed for 5 years with no evidence of recurrence of your colon cancer, it is unlikely that it'll ever return. And at that point, really the important thing is to make sure you don't develop a second colon cancer, and that's done with colonoscopy. If your doctor has told you you have stage 4 colon cancer, basically he or she is telling you that there is evidence that the cancer has spread outside the colon and outside of the lymph nodes in the region of the colon cancer. We also call this distant spread. This is most frequently seen in the liver with colon cancer, although metastases can also occur in essentially any other part of the body. The most frequent, other than liver, would be lymph nodes in the abdomen. Inside the abdomen itself, or what we call the peritoneum, or in the lungs. Lung metastases are somewhat more common for patients who have rectal cancer compared to patients who have cancer of the colon. Stage 4 colon cancer is much harder to cure than stage 3 colon cancer. And for some patients, unfortunately, if the disease has spread to many places or there are many spots of colon cancer, the disease cannot be cured, and treatment is aimed at other things like prolonging life or trying to improve the symptoms associated with cancer. For some patients, for example, those who have a few spots confined to either the liver or the lungs, surgical therapy is appropriate and can sometimes be curative. For the majority of patients with stage 4 disease, chemotherapy and what are called biologic therapies would be the mainstays of therapy. Chemotherapy drugs are intravenous drugs aimed at damaging DNA or other components of cells that are present both in normal and cancerous cells. Chemotherapy works because of differences between normal and cancerous cells, but also have effects on the normal cells. Biologic therapies or targeted therapies try to exploit abnormalities in the cancer that are not existent in the normal tissues and sometimes can have better side effect profiles. But for colon cancer, chemotherapy still remains our most effective type of therapy, and the biologic therapies tend to perhaps help chemotherapy but cannot be substituted for chemotherapy altogether yet. The main types of chemotherapies we use for colon cancer when it is metastatic include 5-fluorouracil, or its oral substitute capecitabine, oxaliplatin, and irinotecan. Sometimes these are used in combination. Common combinations include 5-fluorouracil plus oxaliplatin, which your doctor may call Folfox, or 5-fluorouracil and irinotecan, which your doctor might call Folfiri. Very often these drugs are given together with one of the biologic agents called bevacizumab. Bevacizumab is an antibody that has been designed to stop the tumors from producing a growth factor called VEGF, VEGF. VEGF is a substance that allows the tumor to make new blood vessels, and we believe that stopping the tumor from making VEGF or getting rid of the VEGF can help the chemotherapy be more effective in treating the cancer. Another type of therapy that is a biologic therapy is aimed at something called the epidermal growth factor receptor, or EGFR. There are two antibodies that have been designed to block EGFR. EGFR is, again, something that some cancers are dependent on. It's what's called a growth factor. So if the EGFR is active in a cancer, it is telling the cancer cells to grow, to divide, to live instead of die, and blocking that signal can sometimes stop the growth and even cause the cancer cell to die. The drugs that target EGFR include cetuximab and panitumumab. Those drugs also are often given along with one of the more traditional chemotherapies I described before, such as irinotecan or oxaliplatin. Many patients with stage 4 disease will remain on chemotherapy for a long time. Survival of patients with metastatic colon cancer has consistently improved since the late 1990s, as we've had more and more drugs approved for treatment of this condition. Some patients even live many years with metastatic colon cancer that has not been removed surgically. Often treatments are given in sequence. For example, your physician might give you one combination of chemotherapy for some time. When he or she finds evidence that that combination is no longer controlling your cancer, he or she might switch you to a different combination, and there are several possibilities, or what we call lines of therapy. You may also wish to ask your doctor about the possibility of treatment breaks, because patients who have done very well with a particular type of chemotherapy may put their cancer into enough of a remission that stopping chemotherapy for some period of time is reasonable. Although for the most part, patients with stage 4 cancer tend to stay on chemotherapy more often than not throughout the course of their disease.